Hi everyone, I'm Ayesha Minhaz. I'll be moderating today's panel. I'll invite the speakers before it's too late. We have with us Archana and Sapna. Please come as I introduce you. So Archana will speak from the practice point of view. Archana has been a gynecologist for nearly 20 years. She has worked across many cities and she is a passionate advocate of, helping women amidst the misinformation and gaslighting and all those things. And Sapna is a women's health researcher who has worked with many women's organizations, including Seva. And currently, Sapna is the principal investigator for hysterectomies, the project on hysterectomies in India. So, hi. Thank you so much. That's lovely. Before we get into details of what issues are ignored, wanted Sapna to talk about why there's so much silence about gynecological issues, right? Because if you see social media spaces and everywhere else, we have so many conversations where women are constantly talking about feeling ignored, feeling gaslighted, or using the phrase quite often, as Punari said, but feeling that they're not being heard enough in clinical settings. But that's not about all issues, right? Women often feel ignored when they're talking about issues beyond pregnancy and periods. So I wanted Sapna to begin speaking about what kind of evidence do we have to support this feeling ignored, and what are policies pointing us towards? Could you throw some light?
Sure. Thanks, Ayesha. Oh, okay. And thank you all for having us here today. You know, the short answer to your question about what we know about women's health beyond pregnancy, from an evidence point of view, is not very much. And I think this has been the story, not just in India, but the world over. When we think about women's bodies and we think about women's health, we look at it in two ways. There are things that are specific to us as women, biologically, that only women experience who have a uterus, for example, and the reproductive system. And then there are the different ways in which women experience illnesses that affect all of us, like COVID, for example. And we saw very different things happening between men and women. From an evidence point of view, unfortunately, we know very little about even basic things about how men and women experience disease differently. And then when we come to the reproductive, in terms of what women go through, I can't tell you, for example, nationally, what proportion of women have painful periods. We just don't have the data. What proportion of women in India have endometriosis? We don't have the data. I can tell you the age of menopause, but I can't tell you about women's experiences because we simply don't have that evidence. And that really reflects, in a sense, the way we've conceptualized women's bodies. It's really been focused on maternal health, and in some ways, historically, rightfully so, given the high maternal mortality in the country earlier. But today, what's happened is, after that data has been sort of nationalized and collected, we know very little what happens to women, when they menstruate, for example. There's a lot around adolescent girls, but we don't think about the fact that women continue to menstruate for quite a long time after their adolescence. Yet we never talk about it. You don't hear it. You don't hear about endometriosis. You don't hear about menopause, and we simply don't have the data.
So how do the policies contribute to this not having data part?
So, in a way, I think the policies and science and policy in many ways reflect society and what we prioritize and what we normalize. So we don't have a women's health strategy, for example, and we're not the only country. Most countries in the world don't have a specific women's health strategy. We have specific policies on hysterectomy or a specific policy on maternal health or on adolescent health. But looking at women through the life course, to me, just reflects that basic social norm, is that silence around gynecology and that silence around women's bodies beyond, again, their role as, the potential to bear children. So when we think about the policies, we have to think about that in the context of what conversations are happening in society, which is why it's so important to be talking about these things publicly and to hear about what women are experiencing, to then see a shift. And, the world over, these policies have shifted when more women began to talk about the issues.
Okay, so I'll segue into the norms and, various factors coming into play. gender itself is a marginalization, as you spoke, but we have other marginalizations playing at hand. We have, as country as diverse as India, we have cultural norms, social norms, and then to add to it, we have deficiencies in medical training too. So how are these feeding into each other?
I think the biggest social norm, again, that we're struggling with is around the silence, but also the idea of the uterus. And something that we hear over and over again in our research is that it's dispensable. It's only there to have children. We've studied the words for uterus around the country, and it's usually something to do with a sac, in a body, is something that holds a baby. But then beyond that, the fact that this actually impacts women's health through the life course is not. And that, again, medical training reflects how we think about women's bodies. There's about a paragraph on menopause, I believe, in gynae textbooks. Most clinicians have not been trained in menopause. They haven't been trained in really the new endometriosis, sort of the research that's been emerging. So again, these things feed into each other. Medicine, society, like art and life, completely reflect each other. And until we see, I think, the medical training start looking at women's health well beyond pregnancy, we'll continue to see these gaps.
Okay, thank you, Sapna. Archana, let's move on to the practice side of it. So there's so much silence about most gynecological issues. So what are the consequences of it? How do you see it manifesting in a clinical setting?
Well, if we look back to where we are today from where we were 20 years ago, I think we've come a long way. The very fact that so many women and men are taking time out to be here today, we all deserve a round of applause. And to bring these topics out into the forefront. But having said that, in my clinical practice, I will still say it's highly disappointing that educated, financially stable women still don't make enough effort to learn about their health. It's furthest from their mind most of the time after the Dobiwala, Big Basket, and Amazon, and the priority of the day. But, and a lot of their information or decisions is based on hearsay. There's a lot of Chinese whisper going on. Everyone, and by the time it reaches the end user, the patient, it's totally distorted. So if I feel in my practice where the problem starts is, yes, there's a huge gap between the information available, but is not knowing what is normal. If you don't know what is normal, and if you're told what you're troubled with is normal, then you're never going to reach out for help. So I would say the crux of the problem is knowing what is normal.
Okay. If we have to get into specific, what kind of non-pregnancy issues do you think, do you see women enduring for too long? Whether it's endometriosis, PMDD. Could you elaborate on that kind of?
I guess it starts right from the beginning, the first period, celebrated like a marriage all over the place. And then there's a hush, there's a shh. No one talks about it anymore. The period is forgotten after that first ceremony, and she moves forward that way into becoming a young woman where we are not equipping them enough to know, again, what is normal. Do you clot during periods? Do you have pain? What are the different products available out there? And it is not discussed openly. I think mothers and teachers are doing a better job, but on the whole, I'd like to say, I still get a lot of young girls at 6 grams hemoglobin, 7 grams hemoglobin. I do see women who have struggled with heavy periods to the extent that their work suffers. And we can extend that to even when we talk about painful sex. It's not just the young bride, even those in mature relationships struggle, they suffer. And they're told it's all right, it's okay. And it's not. Sex need not be pleasurable all the time, but it need not be painful. It need not be uncomfortable. And you have to know that before you can go and ask for help. I would say one of the most difficult things are painful periods. Heavy painful periods really take a toll on women of all ages. And then they're told, it's okay. Sabko hota, you have to endure it. And who's giving you this information is maybe the empathetic person who's gone through it. But I would say a half empathetic person who has gone through it and says, if I could get through it, you get through it. Or worse, is someone who's had easy periods and thinks you're faking it. Now, we can fake many things in life, women. We're really good at it. But this is one thing you won't fake. The painful, heavy periods usually has a reason. Endometriosis is is something that probably many people here would not have heard of, so debilitating, can be managed better. So I guess the one that I feel is the most important would be, when we talk about the gap in awareness between what's happening out there extends to even contraception. Most people know the big C, condom. Everyone knows that. Wonderful. It has its places, but there are many other options, which you would be surprised in a practice like mine, how many people come in a day saying, how can I prevent a pregnancy safely? They don't come. And even worse is they face the consequence when they don't know about how to have an abortion when they have a pregnancy they don't want. So there's a lot of gap happening here that, probably it's just because no one, again, knows what is available and what is normal and abnormal.
I'll just quickly ask Sapna about a question because we are talking about personal biases, right? So there's a lot of conversation about normal and abnormal. And there's a lot of discussion about, is the misinformation coming from the patient side, or is there also a lot of or medical apathy? So what do you have a comment on that? Like, there's this constant tussle happening these days, right?
Yeah, and I think this extends to our big public health issues. I mean, something I work a lot on are hysterectomies. And when I meet with gynecologists and doctors' associations, they often say, well, the patient wanted it. The patient wanted the C-section, or the patient asked for it, and it was her demand. And then the patients will say, well, we didn't know what our options are. We don't know what the options are. And I didn't know there was an option, that I didn't need to remove my uterus, or perhaps I didn't want. So this tussle is very much there. I think, again, it goes back to a couple of things. One is our medical training itself, in terms of where the focus is. Like I mentioned earlier, there's very little on the gynecologic aspects in medical training, but also perhaps a medical culture of intervention in women's bodies has become quite normalized. And I think that's true when we look at our data nationally. We just see huge levels of intervention, starting with sterilization as a primary form of contraception, then moving into C-sections and moving into then surgeries later. So where is it a question of misinformation? I think it's more a question of, uneven information in terms of patients not having access to the right information across the classes. And this is not limited to just rural vulnerable women. This is across the board. And I think you see that in your own practice. Where do they get the right information from? But also this fear of the doctor, this inability to be able to advocate with your doctor, in the sense that women, when they express their pain or their issues, feel this distrust. And this has been written about the world over. The idea that, women they may be more dramatic, and they don't express their pain in a way that's objective, which is ridiculous. And until we can actually say that women are the best informants of what their body's experiencing, I think it's a massive culture shift we need.
If I could add that, I think where the biggest problem that I see in a culture like where we are right now is that there's no bigger example than the women sacrificing their uterus just to alleviate pain or heavy periods, and there are no qualms about it. I'm having trouble, take out the uterus. And yes, I do know that doctors are involved in this because, hey, we're the ones removing it. But there's a lot that goes behind that, and that should be discussed. It's not just removing the uterus, is why we doctors are removing it. And I would again say the biggest conversation, or the lack that I see that's happening, which hurts me, personally, is the universal inertia to acknowledge what is the perimenopause and the menopause. And the lack of respect shown to women who are going through this journey of life after they have completed so much for their family, the society, and then bang, you reach this point and there are too few people who are worried about it. So a lot happens from the doctor's side, yes, but the patient has the responsibility to come to the doctor, and the right doctor, to get the information they're looking for.
Right. Thank you, Archana and Sapna. Since you mentioned perimenopause and menopause and hysterectomies, I wanted to ask both of you, whoever wants to comment on that, why do we treat uterus as a whole separate entity? Not talking about pregnancies, but how are we handing out hysterectomies so easily, as if removing a uterus is not going to impact the rest of the body, right? So why are we not talking about the whole interconnectedness of it? So any comments on that?
I think we'll both have something to say. Look, for those of you who don't know, it's early hysterectomy, so taking out the uterus by the age of 30, 35 is incredibly common, particularly in Andhra and Telangana, where up to 1 in 5 women have had their uterus removed by around 32. So this is something, and the implications of that are we are throwing an entire cohort of women into menopause. And they're going into early menopause. And there are data, again, the world over that have emerged that the risks of that include almost everything to do not with the uterus, but rather your risk of stroke, of dementia, of osteoporosis, and the list goes on in terms of the sort of health risks women are facing because of this. So this is not just an operation to remove an organ that people see dispensable. So I'd say number one, to answer your question, the understanding that women's reproductive systems and the body is interlinked with all of their later wildlife being has literally only emerged in medical science in the last couple of decades. I mean, this medical knowledge, and I think there's this great quote, I think she's the director of the Office of Women's Health in the US, says we literally know less about every aspect of women's biology compared to men. And this goes with that understanding. So when that hasn't really permeated down, the idea that this is all connected, you think that, okay, the uterus has done its job. It's now a pain. I can't go to work. I'm bleeding too much. It's difficult. There's taboos around menstruation, whatever it may be. Let me just take it out. And it's seen as pragmatism. It's seen, and I understand it. I'm empathetic to that pragmatism. You haven't been offered an option. There are no alternatives in the system, really. There's very few. And the understanding that this will infect your health for the rest of your life it's really just not... it's not permeated sort of the wide stream understanding of women's bodies. So it goes back to what I said in the very beginning, that until we start talking about women's bodies as a whole, rather than chopping them up into different life stages, this will continue. And this spate of early hysterectomies we've seen across Andhra, Telangana, and then other states in the country as well, it is the real epidemic or the sort of crisis of it is that the fact that the women are so young, and it's being seen as a sort of pragmatic, practical, prophylactic treatment. You're scared of cancer, you're scared of something. And until we reformulate our understanding of women's bodies, I fear that no matter what happens with medical practice and the idea of medical ethics, we'll still always be faced with this demand as well, because the understanding that the uterus is connected isn't as mainstream.
Archana, you want to say something?
Actually, about this, I think we've said enough for the moment, because I see the crowd out here and there's a lot of young ladies. And I would like to take a chance to talk a bit more on that. That concerns me, basically, is, see, luckily for women, we're not that complicated. Though people will say to the otherwise, our problems, our ailments are not that tricky. You don't need a magician. You sometimes need a good listening ear to understand what's going wrong. And this is something I think that's important, that you have to first, reach out in the right way to have, your problems addressed. And that's what I wanted to talk about. And if I could highlight some things that I think would be a game changer, something that everyone sitting here can take back is, would probably prevent these early hysterectomies, because why we have the hysterectomies is that bleeding is a pain, right? It takes back many days from you and your work or whatever you're having to do at that moment. So the menstrual cup, such a simple thing. I would call it the wow cup. Like, it's a total game changer. Unfortunately, it's baffling to me what took so long for it to be invented. But even more baffling is that no one's using it. And why? It gives you protection much longer. You can go about your day. It's inexpensive, safer for the environment by far. It's a bit icky. I agree. If those of you who don't know how to use it, you have to push something up, it collects the blood, and you pull it out. And you clean it and you put it back. And that's about it. So it's a bit icky. Yes, there's a little blood on your hands. But what's a bit of icky in our life when women deal with so much more? So if women who are struggling with heavy periods and cannot go to work, they resort to hysterectomy because they're not trying other things first. Another classic example would be the Marina, the progesterone-containing device called the Marina, I don't even know if anyone knows what Marina is. I could shout from the rooftops, Marina, 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 and they would think I'm crazy. It's a trade name I'm using because it's most commonly known that way. But it's a device that has hormones that you put it inside your uterus and you stop bleeding essentially. So those who are struggling with heavy periods, and just one note here, it's not meant for everyone. It's meant for those who do not want pregnancy any longer. So these are things which will go a long way if brought into the public sector by women of privilege who can change those policies. Someone in the village is not going to say, hey, I want a Marina, right? It has the people who are making the policies who bring things like menstrual cup and Marina into the market for the public, where you're going to see change.
So do you have any comment on why then is contraceptive pill still the most popular solution, not just for contraception, but for a whole lot of...
Well, I'm happy you're saying that you think it's the most popular. In a practice like mine, I don't get anyone walking in maybe more than twice a month, married, unmarried, or otherwise, asking for oral contraceptive pills. And I treat an urban educated class of women because they still believe, right, that by taking those pills, because Dadi Ma, Nani Saas, everyone weighs in and says it's going to harm you for life. You're going to be scarred for life if you resort to oral contraception. Now, okay, imagine this. Go back to the Walkman era. If any of you have ever used a Walkman, go even further back to the cassettes and go further and further back. That's when our pills had a higher dosage. And I agree, there were troubles there. But fast forward to so far ahead now, where the pills are so beautifully made, where they mimic your natural cycle and bring it under to control, forgetting contraception. It is a very viable option for people who are having discomfort during periods. It is a 90% game changer. Again, in the public sector, if they could just be convinced to use it, these are the tools. They're there. They are very much there.
Thank you, Archana. Okay, so we are moving towards the second half of the discussion. We have spoken about what is the state of affairs quite a bit. So if you could give a takeaway, Archana has already commented on that. If you could give a takeaway for women across life stages, what would it be? Yeah, both of you. Across life stages, like covering.
Since I don't see too many adolescent girls here, and we've talked about heavy periods and menstrual cup, I'd like to again talk about the copper tea. Again, because women sitting here advocate for women who work for them in their office spaces or the domestic support team. It's a beautiful thing, pushed into the corner, defamed completely, because people have been told, anyone I bring up copper tea in my clinic, anyone, but I've heard that from the uterus it goes to the liver, and from the liver it goes to the brain. This is what has been spoken about. It's like that auntie no one wants to talk to, totally defamed. So I wish that people sitting here today at least know what is copper tea. And to the contrast is the eye pill, or the emergency contraception. So if this was a fashion show and I had to choose the worst dressed person in this fashion show, it would be the eye pill. Totally misused, mismarketed. It is not meant for the way it's being used. So if anyone out here thinks the eye pill is the answer to their solutions, it is not. And I would love to talk more about it, but no, I'll stop here.
Yeah, thank you. Let's move on to the misinformation ecosystem too. There's a lot of health information out there, which is good, right? But there's also a lot of YouTube, Instagram, Twitter, and the whole ecosystem of misinformation where we are handing out solutions like cortisol tea, herbal tea for PCOS, and quite extremes where you think you can resolve issues which require surgical interventions with teas and diets and gluten-free regimes, right? So in this ecosystem, how are women supposed to find information which is good, which is relevant, and which is not going to harm them further?
It's a great question. It doesn't have an easy answer, as you can imagine. I think these are so individualized and personalized in terms of the extent of someone's problems, the extent of what they can do, and from which systems of medicine they choose. It's also preference. So I think women, as we learn to advocate and understand our own advocate for and understand our own bodies, there's a couple of things we can do. One is find the medical sources of information from whichever systems one trusts, but then be willing to go through that longer negotiation process where you're actually seeking the advice of a few different people, the way in which you would perhaps, I don't know, buy a car. You would also, I'm always amazed that with this, we're too scared in a way often to see the negotiation process through, or it becomes about money as opposed to understanding. So I think it's difficult to answer, say, don't look at Instagram or don't, because there's actually some very valuable information out there on menopause. The menopause conversation's online. It's not really anywhere else. So I would say it's up to us, and this is what's happened in the centuries of sort of the history of medicine, right? Is that it's women who have advocated for themselves, who've learned about their own bodies, speak to groups of women. I'm a big proponent, perhaps my history with women's groups, of the power of the collective, to speak to other women intergenerationally within your peers to understand what others are going through and use that. And we have to use our own voices. So unfortunately, no easy answer except to say we've got to learn to navigate the systems.
Archana, do you have any comment on that?
I mean, it's huge. We all have to agree the power of social media is huge. And just remember, when you're watching a podcast or you're watching a reel, the person is usually giving their experience. So it's like talking to a bunch of auntie, uncles, hundreds of them at one time. And again, if you have a professional podcast you're listening to, that person is talking to a specific sect of people. Let's look at polycystic ovaries, for example. You cannot have any one type of answer for polycystic ovaries. It's a spectrum. You have the adolescent polycystic girl, you have a lean PCOD, you have an obese one, you have a girl who's trying to get pregnant, struggling with polycystic ovaries, you have women in the middle ages struggling with polycystic ovaries. So you don't fit into any one slot. None of us fit into any one slot, but that podcast and reel is meant for one slot most of the time. So I would say use it, read it, or listen, but have a filter. That's what our brain is. It's a beautiful filter if we just choose to use it. And then with that information, I still think if it's a health-related problem, the end person should be your doctor.
Okay. I'll come back to Sapna again, because you are a public policy researcher also. Can you not hear? So, from my experiences from field as a journalist, and of course everyone knows it's common sense that private healthcare is still not that accessible, right? So, how do we, what do you have to say about strengthening public health and, access to information that has to come from the government's end also? Because I think that's going to be inform more people than anything else.
Absolutely, and also reflects the priorities of a country, of a culture, of a society when those shifts happen. So I would say a few things. One is there are certain things that have happened, progress has been made. For example, we now have a national policy on unnecessary hysterectomy, which has been a big move forward because the entire policy is really talking about access to good quality gynecological care. So those words are now there, they're in policy, though of course it'll take time for those to be implemented. I think what needs to happen is starting at the ground in terms of primary health care. Those very centers, the health and wellness centers, for example, at the local level, whether it's urban or rural, have very little for gynecologic care. So to see women's health and gynec care in particular as part of primary health care is our big challenge. And that needs to start low, and then women need to be referred to the appropriate specialists, but also to the appropriate options. And the big thing we're missing right now, I would say, are the options, the alternatives in the public system. So what are the options to treat painful periods and, endometriosis or cysts, fibroids, etc., they're not in the system. What's in the system are a lot of surgical interventions that are free, but what's yet not free are things like the IUD, the Mirena, the IUD, etc., things that can easily be a great solution for women. So again, it's my common theme is that when we start seeing women's gynecologic care as part of primary care, as part of just a basic right, then we'll start seeing those shifts. So I think the information begins there too. Also, if you look at what community health workers, what ASHAs, if you look at their modules in terms of what they talk about, they do go through the life course, but gynecologic issues are largely not there outside of cervical cancer, and that's a problem. And that's where it needs to begin. And I do think, I'm very hopeful and optimistic that as policies are shifting and as more data emerges, like some of the research we're doing, we will be able to push for seeing some of those things, both in grassroots level information, as well as in the services that are available from the bottom up. It can't just sit in the district hospital, which is what it is today.
Right, thank you. Because we do have to accept that public health access and strengthening of the systems is important, because great you mentioned ASHAs, they are overburdened, they are doing almost everything, not just gynecological issues. So it's great. Let's hope that having conversations helps contribute to this. We're moving towards the end of the discussion, I think. We have a few more minutes. So, Archana, okay, so whether it's a private setting or a public hospital, do you have any tips for women to advocate for themselves?
Advocate, yes, but if I can spare 1 minute, because I think the star of today's program should be hormones. Women, we all know the names of Saif Ali Khan's children, Taimur and Jay, but do we know the names of the hormones that are giving us so much of support in our life? And I really want you to go home today knowing that at one spectrum, we have the issue of polycystic ovaries, yes, where it causes so much of heartache to girls throughout. And at the other spectrum, you have menopause, where you think you've, navigated this circus of life and you've reached where you wanted. You're sitting nice and cushy on your chair, and then boom, you're thrown into the fire of menopause. So what I want everyone to go back today knowing is that if you haven't thought about these things, you should be thinking about it. And obviously, this is not the space to go into the details of why a polycystic ovary is important, but it is, because it's not just about your period. It is about, it takes control of your whole body from your mind. It's mentally very disturbing to have hair growing everywhere. It's very disheartening when you cannot lose weight, when you try very hard. And as you get further along, when you cannot conceive, and further along when you get diabetes early, further along when you get, it affects your ischemic blood system as well. So don't be thinking short term always. I know we're not me maybe, but there is a generation of short term gratification, right? But look long term. Polycystic ovaries is much more than acne. Yes, it's a lot more. And similar, I would say, about menopause. But what you asked me in specific was about advocating for oneself.
So my whole point was, most women have 5 to 10 minutes at the clinic.
I got that.
So how do you get most out of that time?
So here's where, if I've been a bit kind, maybe till now, is where I think you have to have the discussion with yourself first. You must be honest about what's going on within yourself. Your brain must know what's happening in your body. And then it's your story. It's your own story. It's not what you Google, copy, paste, and plagiarize a story that you present to your doctor. And we know in 2 minutes. It takes me 3 minutes to know when the person or her attender has done their Google homework and come. But instead, if they just thought, because painful periods doesn't start with the uterus, like she said. There are many other issues that contribute to it. So if you have to advocate for yourself, be honest within first. Yes, go to your doctor prepared. Yes, you Google, you Instagram, whatever. Have points. But go with an open mind and be willing to listen to what the person tells you. Take second opinions, third opinion. Fight for yourself. You don't have to punch your doctor, but fight for yourself for what you've gone for till you get it. Yes?
Okay, thank you. We have a few more minutes, concluding remarks. Okay. So we have some time for concluding remarks. So Sapna, because you are passionate about this also, what can society do? Like, how do you see society contributing more to this conversation?
I think the
broad.
first job we all have, and it's our duty, is to talk about this more. I think to talk more, and then to obviously do more in terms of what we can do. And we're at a literature festival. I mean, the way we even look at women's bodies in literature, in film, in television, if you start honing your eyes on it, you see often what the role of a woman is, and you rarely see even sort of the issues we're talking about, despite menopause. So it's always sort of vilified in a way. So thinking about the way we talk about women's bodies, what we know and what we act, and again, the history of medicine has been such that it has been women. It has been as women, as researchers, as doctors, as activists, as advocates, as patients, who've really been able to change the course of history. So not to think that we having these conversations here, continuing these conversations, and for those of you who occupy different spheres of life, I think, to think about how these issues are impacted, society and medicine are like this, how they impact the way we look at the body, I think is the most important thing, is to start having conversations and to really start talking about these issues, so then they're reflected in the way in which they are acted upon.
I mean, the very fact that we're sitting in a literary festival and saying words like condom and abortion and sex, we've come a long way, and the silence is being broken. But again, the silence starts from within. The brain must be talking to the body about what's happening. The heart has to weigh in. Your heart really has to understand what's happening. And then a lot of soul searching to understand what is your problem. You cannot have expectations that someone else is going to understand what you yourself have not been honest to accept. And with that soul searching, understand your problem, go get answers, and protect your body. I mean, we deserve it. We owe it to ourselves to take better care of ourselves by having more knowledge about our health.
Thank you. We have come to the end of the discussion part, but we're now open for the questions. And just one request is, kindly keep the questions broader so that it doesn't become like a consult, like broad themes.
Hi. Hello. Yeah. Archana, my question is to you. Do you as a gynecologist recommend or prescribe therapy when women are diagnosed with different health conditions? Just to put it in perspective, I was diagnosed with endometriosis like 3 years ago, and I had to go through oral pills, surgery, and now I'm on Mirena, which also isn't working the way it should be. So basically my body has rejected the treatment options, and all my gynecologists could say was that sometimes body works erratically. So I have struggled a lot more emotionally and psychologically to accept that this is a condition that I'm living with and my body is not responding to the treatment options. So I was wondering if you prescribe something for this aspect.
So I'm a big fan of admitting that medicine is not the only option. The tools that I have as an allopath may not serve my patient well, and that's why we have lovely adjuvant in form of yoga. I'm a firm believer that yoga gives you a lot of control over your whole body, yes? And it's for you to go and find that. Homeopathy, Ayurveda do have a place. Naturopathy, your diet itself takes so care of so many things. Water therapy, there are many things, but you have to understand a gynecologist is not legally, one, two, have enough information to hand out things on this, right? So if you go to a gynecologist, we are going to talk only about 1, 2, 3, 4, 5, but we may have people around us who can help you, yeah? But it's not up to us to give you that information.
My question is regarding clinical trials. I work in a space where I set up a clinical trial before the first patient visit, and I've rarely seen women-only trials in the last 3 years.
Rarely seen?
Women-only trials in the last 3 years. I've rarely seen women-only trials in the last 3 years. And I also want to ask about why. Like, if you go to a cardiologist, they ask you, what's your family history? But I think in terms of women, our family history gets left behind. What happened with our moms, aunts, grandmothers. So I just kind of wanted to ask your opinion on those two topics.
You know, that has been one of the great, I mean, I wouldn't say controversy. I think one of the biggest flaws in clinical trials has been the inclusion of women. As you probably know, I mean, the others may not, but, you know, up until the 90s, there were still trials that didn't include women at all globally because of fears around, oh, we don't know how women's bodies act with hormones, or perhaps the women might be getting pregnant. And we literally did not understand what I said earlier, how women's bodies react differently to medicines and to different diseases and the different risk factors. And cardiovascular disease is a case in point. Women actually display it differently, they experience it differently, risk factors are different. So you're absolutely right, and I think this comes back to me in terms of evidence. Until we start seeing sex disaggregated data on everything, where we only understand that we need women in those trials in equal numbers or women-only trials to really understand women's life course. And that is a big flaw in medicine, and comes back to our big conversation around we need to be advocating and talking about the women-specific issues. And just because we can both have malaria and women and men can both have COVID does not mean we experience them the same. We don't. So you're absolutely right, and this is a big issue.
Ma'am, I want to ask two questions. My first one is, I want to know, and I want my peers to know about sex education, but there is no particular document or information on the net available to tell about it or to talk about it among ourselves. So could you inform me if there is any kind such of material? And my second question is that I don't want to be get pregnant. So will my health get affected in any way in the future? And what course should I follow?
I think it's a wonderful question, and thank you for bringing it up. It's a lack of time that didn't allow us to talk about it. I know that you look for information in various sources. I would still say going to the bookstore, or however you people buy books nowadays, and identifying a book that comes to your level of understanding in reading. And as you graduate from the pediatrician, the baby doctor, ask for a gynecologist, because we are the next one in the logical step. You can, because what happens, it is our duty to answer those questions that you have. And yes, you spend 500 rupees in the private sector, but it's a well spent 500 rupees if you have doubts that you want to have sexual intercourse, but you're scared that you're going to get pregnant, so you decline from having sex. Is that your question? And if you use something, is it going to bother you in future? Is it going to is it going to cause a problem in future when you want children? Is that the question?
Or that she doesn't want children.
You don't want children ever. That's a wonderful thing. So if you know that when you're young, my only suggestion would be to someone, we change. Like today I love wearing denim, and tomorrow I love wearing saris. Tomorrow I like having piercings. Day after I may change my mind. Keep options open when you're very young. And if you don't want to have pregnancy, which is absolutely fine, is don't cut it off completely would be my suggestion. There are many ways of engaging in sex without getting pregnant, but keeping the option open later in case something changes in life.
Is going to impact you.
I mean, if you don't get pregnant, is something going to happen? You'll have the best life ever. Because, coming with babies are overrated. Raising children is something that's been thrown upon us because we thought that's what we're supposed to do. And it starts with getting married. Who says? I mean, I wish to be raising a generation of people who know that getting married is not the solution for anything. And having a child is even a worse solution for anything. So no, you will have a wonderful life. And you'll enjoy watching all your peers struggling and maybe be the favorite auntie everyone wants to have at home maybe. But yeah, nothing. Absolutely nothing.
Well done.
That was really beautiful, Dr. Archana, when you mentioned look inwards. And listen to your soul or listen to your heart and figure out who you are, and you don't fit into these boxes, right? And each one of us is an individual. But one question to Ms. Sapna is also that probably the policies and all of this is good, but then I think there should be more awareness in terms of celebrating ourselves. So every time we talk about periods or, pregnancy in some sort, all of us only talk about problems, but we are not actually celebrating. Like Dr. Archana mentioned, the first period is a celebration, but I still never understood why only the first period is celebrated. In fact, I didn't want that celebration because it put me out there saying that, hey, the suffering starts. And the way the society is going to look at me is going to be very different, right? And everybody is going to preach to me as to what I should be conscious about, how the society is going to treat. So probably a woman per se probably should be started, each one of us should start celebrating ourselves, and maybe the policies and the government should be encouraging it, maybe. I don't know. It was just a thought I just wanted to share on this platform.
Thank you for raising that, and you're absolutely right. When we talk about sex, we talk about sexually transmitted infections. We don't talk about pleasure. And you don't see, the conversation tends to be all the things that can go wrong. And even someone like me, when I'm advocating for, more attention to women's bodies, we're often talking about the illness as opposed to just the enjoyment of it. But again, like I said earlier, I think policies in medicine reflect society and they go back and forth. So you're right, this is the place of society and culture, of art, to also be celebrating women's bodies as a whole. And then I do believe, I don't know if it's just the role of policy, I think it's the role of us as a society as a whole, to be thinking in that lovely way you articulated it, the pleasure of.
Maybe the value of intergenerational friendships. I'm a big fan of that, and it's so lovely. I know personally people here have come with people older or younger, and that's where the fun starts. It's that whole, I don't know if you've read The Red Tent, any of you. It's a biblical era. It's about Ruth and how they all used to go to the red tent when they were menstruating, and there would be women there from, the older women, right, to the youngest girl who's just started her period. And they would all sit in that tent for those 4 to 5 days. Yes, regressive, I agree, but they used to have the time of their life discussing being a woman and celebrating. That was not a curse. They waited for their period to sit in that tent and have fun. Yeah.
And that actually speaks also to the power of the collective and women's groups. The history of women's groups actually started in this very state in the country, right? In terms of really organizing in many ways, but also organizing to allow women that enjoyment of being able to talk freely and to be talking about their bodies and their problems, but also the joys.
I have a hi. I have a question at the end, but basically 2 comments to start with based on what Dr. Archana said. Dr. Archana mentioned that sex need not be pleasurable. I definitely do not agree with it, because the alternative to that would be sex for reproduction, which brings us back to the concept that the uterus is what makes the woman. That's the first part. The second part, I kind of felt that there's a lot of onus being placed on women advocating for themselves. I'm in my middle age. I'm very easy, or I can comfortably go and advocate for myself. But what I feel is the medical community does not listen. The medical community does not listen to what we have to say. The medical community does not even use words like intercourse. I've heard things like when you meet your husband. And we talked about Mirena, which is the hormonal IUD. Popularly, in most practices, that is being suggested only to married women. So the point is, my question is, what is the medical community doing to actually acknowledge the fact that women are getting more informed right now? Women want to know more. Are there any changes that the medical community is doing to address their biases and to change the way they are offering treatment?
So they're scared of you.
I don't want anyone to be scared of me.
No,
really.
I'll tell you why. Because, see, I love such questions. I love patients who come in challenging me that way. And it's a rarity. And I would have the happiest day in my practice if someone came and asked me these questions. They're rare. So it's a very quick analogy, and you might think it's really dumb, but I use it a lot, is that you're flying from here to London, right? You have economy, first class business, you're paying 40,000, 1 lakh, 1.6, same pilot, you reach at the same time. Your experience is different. You will have to find a doctor who is going to give you that time to listen. And what I do in my practice is, if they've come in for a routine checkup or appointment, and I see I'm running out of time because I am obligated to meet my other patients, I say, look, I'm free at this time every day. Come back in and we will schedule. Now, I'm not saying I'm great, but I'm saying there are some who are trying to do a better job. And as far as sex being pleasurable, yes, it's wonderful if it's always pleasurable. But I think many of us who are in relationships or not in relationships can say that it's not always is, but sometimes done. And you don't do it thinking, am I going to get pleasure or not? You're anticipating pleasure, but it may not always happen. But it should not be painful is my point. That is what I'm saying. Was the point of this, where people are suffering from painful periods. And if you're not finding pleasure in sex, you have to look at other avenues. If you have no pathology, are there other things you can be using? Is what is missing in that relationship that you're not finding it pleasurable? That's what I meant to say.
I think there's a growing role and a really important role of patients groups to advocate with the medical community, and you're seeing that more and more. And you're right, the medical community may be scared of this as well, because it is pushing things to change, but this is how change has always happened. So I agree with you. I think it's unfair when we put too much onus on women, saying get your own information, do this, and expect not much from the other side. But I do think it happens in tandem and perhaps in conflict as well over time. And that's where we're going to see the changes. We see small changes. I see conversations in policy now talking about data being collected, talking about new types of evidence coming out. But I do think a big area of potential is just, if people are suffering with endometriosis, for example, to talk to 10 other people, but not to even just keep the conversation there. But we now have the tools to make that more public as well. And that's the sort of pressure I think we can bring upon the system as well.
Again, when you say onus on the patient, I do understand that it's very difficult for patients to advocate for themselves. But again, it's for you only, na? There are so many people who are fighting battles for people around them. So make that extra effort to come out and understand. For example, something like Marina, if there's a room of 100 gynecologists, I can count on my finger how many of them have personally had one and how many have actually put one in someone. Same with menopause. There's a group of thousands of women on a WhatsApp group of menopause, all women over 60. Not a single one will be on hormone replacement therapy. You understand? So these are areas that the gynecologist herself is not comfortable with many times. So find the right doctor.
Okay, I think we have to wrap up because of the lack of time, but you can speak to them after the session, right? So I think I'll just end on the note saying that as a woman, I'm not speaking as public health or gynecological expert, but I think we would know when something is not right? So probably just hold on to it, because there's been some discussion about pleasure and painful sex, but I'm like, don't endure it. You don't have to endure it, whether it's about pleasure or pain. So just wanted to end on that note. We have to wrap up this session because someone else is waiting for the next panel, but you will be free for a few minutes to probably talk with the audience who didn't have their questions answered. Thank you, everyone.